Usually when you picture, like, a medical diagnosis being made, there's this expectation of clinical, almost cinematic precision.
Oh, totally. Like a TV show.
Right. You think of a detective walking into a pristine crime scene, you find the fingerprints, you run the DNA through a computer, and boom, the culprit is right there in black and white on a lab report.
Yeah, it's a very comforting thought. I mean, an objective number on a piece of paper just feels safe. It gives this illusion of absolute certainty.
It's clean. But then you step into the world of rheumatology, and suddenly that pristine crime scene is just totally gone. Instead, we're looking at, well, a dusty, chaotic basement full of cold case files. So today, for you listening, our mission in this deep dive is to explore what is arguably the most subtle and honestly often completely overlooked art in medicine, which is clinical history taking.
Which is, I mean, the absolute definition of diagnostic muddy waters.
Mm-hmm.
The reality of rheumatology is that it is incredibly messy, deeply complex, and completely reliant on the human narrative.
Yeah, we are essentially looking at a masterclass in medical sleuthing today, because this isn't about a doctor just walking into a room, poking a joint, and asking, so where does it hurt right now? It is about how seemingly irrelevant, totally forgotten details from a patient's past hold the literal key to their present suffering. And to ground this, we are opening up a specific case file from our source material right away.
Yeah, this specific patient is a really perfect anchor for what we're going to discuss today.
So we have a woman presenting with severe joint pain. It's chronic, it's additive, meaning it's spreading to more joints over time. And she has significant morning stiffness that only improves after she gets moving. But here is the hook. Almost in passing, completely offhand, she mentions this strange stretch of heel pain she had back in her 20s.
Right.
It lasted for a while, and then it just eventually went away on its own. She never thought it was connected to anything. So let's unpack this. As a clinician, how can a forgotten random ache from a decade ago possibly connect to the severe joint pain this patient is feeling today?
Well, what stands out here is that this perfectly illustrates step 3 of the 5-part diagnostic framework we are working through. And step 3 is the history. I really want to emphasize that the most crucial, heavy-lifting diagnostic work happens right here in these seemingly casual conversations. Very often, the diagnosis is practically made before a single lab test is ever ordered.
Wow. Before the blood even gets drawn.
Long before. A purely present tense focus, like just asking, when did your knee start hurting, is completely insufficient in rheumatology.
Yeah.
That old heel pain isn't just a fun piece of trivia, you know.
Let's transition into how those old clues actually function, because this brings us to a concept that completely changed my perspective reading through these sources. We might call it the, now that you mention it, phenomenon. We are shifting from just this one woman's heel pain to this broader, honestly mind-blowing concept that historical blips in our health are actually chapter 1 of a current disease.
Yeah, let's look closely at that heel pain. A transient episode of heel pain occurring at a younger age could very well represent Achilles tendon enthesitis.
Actually, I'm going to pause you there because we definitely need to define that. What exactly is enthesitis?
So think of a tendon or a ligament like a heavy rope anchoring a ship to a dock. The enthesis is the dock. It's the exact point where that fibrous tissue inserts into the bone. Enthesitis is inflammation at that specific anchor point.
Okay, got it.
Or, alternatively, that heel pain could have been plantar fasciitis, which is inflammation of the thick band of tissue across the bottom of the foot. To a skilled clinician, that seemingly resolved symptom from 10 years ago is a massive clue. It points directly toward the ankylosing spondylitis and spondyloarthritis group of diseases.
Wait, even though the pain went away completely on its own?
Even then, the disease didn't disappear, it just went dormant, or it shifted its focus. And the clues go far beyond heel pain, too. For instance, a past episode of uveitis, which is a specific, really painful type of inflammation inside the eye, can point to the exact same group of joint diseases.
Okay, wait, I have to push back here on behalf of everyone listening. You're telling me an eye problem from years ago is biologically the exact same disease as a swollen knee today?
It is part of the same systemic process. The immune system isn't isolated to one body part, and the web of connections gets even broader than that. A patient might have a recent history of a febrile illness, meaning a fever, with or without a rash.
Right.
Or perhaps they have a history of a specific sexual contact leading to a venereal disease. Or maybe just a random acute episode of diarrhea from food poisoning. Even acute conjunctivitis, commonly known as pink eye.
Pink eye.
Yeah. Any of these events can be the foundational clue pointing toward inflammatory conditions like reactive arthritis, gonococcal arthritis, or peripheral
A
spondyloarthritis.
stomach bug, like a random bout of diarrhea a year ago, could be the key to diagnosing knee pain today. That is wild. How does the stomach even connect to the knee?
It comes down to a fascinating mechanism called molecular mimicry.
Molecular mimicry.
Yeah. Think of it like friendly fire. When you get a stomach bug, your immune system builds a highly specific weapon, an antibody designed to attack that specific bacteria. The immune system fights off the bug, you recover, and everything seems totally fine.
Right. You go about your life.
Exactly. But a year later, that same antibody is still circulating in your blood. And it encounters a protein in the cartilage of your knee that happens to look chemically identical to the stomach bacteria.
Oh, man. So the immune system gets confused. It thinks the knee cartilage is the stomach bug returning.
That is the exact mechanism. It launches a full-scale attack on your own joint. So the stomach bug was the trigger, but the arthritis is the lingering result. This perfectly explains the pattern of the day that, now that you mention it, moment, picture a doctor sitting there asking a totally unremarkable question. Have you had any eye problems recently? Any stomach trouble in the past year?
And the patient is probably sitting there thinking, why are you asking me about my stomach? I'm here for my elbow.
Right, because patients understandably compartmentalize their health. They think, I go to the eye doctor for my eye and the gastroenterologist for my stomach.
Huh.
But then during the interview, their face shifts slightly, and they say, well, actually, now that you mention it, I did have a terrible stomach bug after eating at a restaurant 6 months ago.
Wow.
That pause, that hesitation, that is where the real diagnosis is hiding. It's buried under a symptom the patient never in a million years thought to connect to their joints.
Because a resolved symptom is often just the disease introducing itself early. It's knocking on the door, saying hello, and then just walking away for a decade.
It is the same systemic issue. Different chapter, same book. Proving that systems in the body are deeply connected is why the clinical history is so utterly vital.
So if these historical clues are so powerful, why do they get missed? Because it seems like it would be incredibly easy to just skip the deep conversation, especially for a clinician who is maybe rushing through a 15-minute appointment. What happens when doctors rely on assumptions or like those hard lab numbers we talked about earlier instead of doing this historical digging?
Well, the clinical reality is that doctors fall into diagnostic traps. The sources detail 3 genuinely classic traps in everyday rheumatology practice. They're incredibly common, and they're dangerous precisely because they feel so logical in the moment.
I want to walk through these because they sound like cautionary tales. Trap number 1 involves tuberculosis, which, sounds completely bizarre in the context of joint pain.
It does, but it happens. A young patient presents with monoarthritis or oligoarthritis, which just means pain and swelling in just 1 or maybe 2 or 3 joints. The clinician looks at this isolated swelling, skips the deep history, and makes an assumption. Because tuberculosis can occasionally present in the joints, they treat the patient empirically for TB.
They just guess and give them TB medication.
Yes. And trap number 2 follows a very similar pattern of hasty assumptions. That same young patient with a few swollen joints is misdiagnosed with rheumatic fever. In these cases, the clinician might even treat the patient empirically with heavy doses of long-acting penicillin.
So the patient goes through all this intense, heavy-duty antibiotic treatment just based on a hunch.
Exactly. Only to watch the condition continue to evolve months later.
Yeah.
Given time, the disease reveals its true colors. It wasn't tuberculosis, it wasn't rheumatic fever, it was enthesitis-related arthritis all along, and the antibiotics did absolutely nothing.
This brings up a really compelling concept from our source material today, something called the vault. It's the idea that a failed treatment is actually a huge piece of the puzzle, not just a mistake to sweep under the rug.
This is a vital lesson in medical sleuthing. A treatment response, or in the case of the penicillin for suspected rheumatic fever, a complete lack of a response is not just a therapeutic afterthought. It is actual vital diagnostic information.
Right.
If you give a targeted treatment and it fails completely, that failure is a data point telling you to pivot and look at an entirely different disease pathway.
You're ruling a disease out by failing to cure it. That's a high-stakes way to practice medicine. Let's look at the third classic trap, because this one involves lab work.
Right, so the third trap is diagnosing someone with gout based purely on an elevated serum uric acid level on a blood test, without having the clinical picture, the actual physical symptoms to back it up.
I love the analogy for this one. It's like treating a high uric acid number on a lab report, like a check engine light on your car dashboard. You see the light, you blindly trust it, and you start tearing apart the engine, totally failing to realize that the sensor itself might just be glitching. You end up treating the little glowing light, not the actual car.
That is a phenomenal way to picture it because it highlights the fundamental danger of numbers. A number on a printed lab report feels objective and authoritative, much more so than a patient's vague memory of heel pain.
Yeah, exactly.
But that authority is often a complete illusion. Uric acid levels in the blood fluctuate wildly.
So the blood test isn't telling the whole story.
Not at all. In fact, a patient can be in the middle of a massive agonizing gout flare-up, but their blood uric acid test comes back totally normal.
Wait, really? How does that happen?
Because all the uric acid has left the bloodstream and crystallized inside the joint. The lab test looks totally fine while the patient's toe is the size of a tomato.
Okay, wow. So if the clinical picture, the actual physical symptoms, the history, the geometry of the pain doesn't match the uric acid number, the number is basically leading you off a cliff.
Which is why, to avoid these easy trapdoor diagnoses, a clinician really has to do the hard work of building a bulletproof suspect profile of the patient.
Right, moving away from flawed lab tests and looking at the human being wrapped around the joint. We are talking about triggers, genetics, and demographics. Where do you even begin building a profile like that?
Well, you start with environmental triggers. Cigarette smoking, for instance, is a recognized direct trigger for most types of inflammatory arthritis, rheumatoid arthritis in particular. Is absolutely worth asking about directly.
Most people think smoking just hurts the lungs. How does inhaling smoke cause your joints to swell?
It goes back to the immune system again. The toxins in cigarette smoke actually chemically alter the proteins in your lung tissue. Your immune system patrols the lungs, sees these newly altered proteins, and registers them as alien invaders. So it starts producing antibodies to attack them.
Oh, I see where this is going.
Yep. Just like the stomach bug, those antibodies eventually travel through the blood and find similar-looking proteins in the lining of your joints. The smoking lit the match, but the joints burned down.
That is terrifying, honestly, but fascinating. And then you layer on family history, which carries incredible weight.
Yeah, think about a patient presenting with what looks like seronegative inflammatory polyarthritis. This means they have multiple inflamed joints, but all the standard blood tests for rheumatoid arthritis are coming back negative. A clinician might be completely stumped, but if they dig into the family history and find out a blood relative has psoriasis, the skin condition that changes the entire investigation.
Wait, even if the patient with the joint pain has perfectly clear skin themselves?
Yes. They might actually have psoriatic arthritis, but the skin manifestations just haven't appeared yet, or perhaps they never will. The genetic link is that strong. The significance of family history is also obvious in other strongly hereditary conditions. Ankylosing spondylitis and gout very often have a clear trail of positive family history across generations.
So we have environmental triggers like smoking, we have genetic links like psoriasis, let's layer on the demographics, age, and sex. The source material breaks this down really specifically, painting a picture of how different diseases prefer very specific stages of life. Let's look at why certain age groups are targeted.
Age provides a really powerful filter. In children, if you see arthritis, you should primarily be thinking of juvenile idiopathic arthritis, complications from hemophilia or simple physical trauma. Kids fall out of trees, or they have specific pediatric autoimmune conditions.
Right. What happens as they transition into adolescence and young adulthood?
The net widens significantly. In adolescence, we still see trauma and juvenile conditions, but now rheumatoid arthritis, spondyloarthritis, and post-streptococcal reactive arthritis enter the picture.
And young adults.
Moving into young adults, trauma is still high, but gonococcal arthritis rises sharply in likelihood.
Which tracks logically because young adulthood is often when sexual activity increases, linking back to those sexually transmitted infections triggering joint inflammation.
Exactly the connection we need to make. Now, broadly speaking, for adults, the profile shifts to spondyloarthritis, reactive arthritis, systemic lupus erythematosus, often just called lupus, which is a systemic autoimmune disease affecting multiple organs, along with psoriasis and gout.
And then into middle age.
Once you hit middle age, you are primarily looking at rheumatoid arthritis, gout, osteoarthritis, and scleroderma.
Osteoarthritis being the classic wear and tear of the cartilage over decades compared to the immune system attacks we've been discussing, right?
Yes, a crucial distinction. And finally, in older age, that mechanical wear and tear of osteoarthritis, along with a condition called polymyalgia rheumatica, completely dominate the landscape.
It really is like an FBI suspect profile. If the crime of joint pain happens in a 10-year-old, the list of suspects is completely different than if it happens in a 65-year-old.
The demographic context dictates the probability, and sex is the final major demographic filter. Broadly speaking, the vast majority of autoimmune and inflammatory joint conditions are heavily female-dominant. This is likely due to complex interactions between the immune system, genetics, and female hormones.
Are there any notable exceptions? It seems like an almost exclusively female-dominant arena.
There are a few, actually, and we can think of them as the brothers of rheumatology. They form a highly specific, memorable list that goes against the general pattern. Gout, ankylosing spondylitis, reactive arthritis, and polyarthritis nodosa are all male-dominant conditions.
Gout, ankylosing spondylitis, reactive arthritis, polyarthritis nodosa, the male exceptions. It's fascinating how these conditions map themselves onto human demographics, which transitions us perfectly from who the patient is to where it hurts. We have to look at how the pain physically manifests on their body.
Right, we are looking at the geometry of the disease.
The geometry of pain. We are looking for patterns in the body's architecture. The two big concepts from the sources here are symmetry and joint size. Let's start with symmetry. Why does it matter if both wrists hurt versus just one?
Symmetry is a profound mechanical clue. When a condition is symmetrical, meaning it affects the left wrist and the right wrist equally, or both knees, you are generally looking at rheumatoid arthritis, lupus, progressive systemic sclerosis, or juvenile idiopathic arthritis.
Why do they mirror themselves across the body like that?
Because they are systemic conditions floating in the bloodstream. The autoantibodies are traveling everywhere. When the blood washes over the joints on the left side of your body, it's also washing over the right side. The attack happens symmetrically.
That makes total sense. And if it's asymmetrical, say a severely swollen left ankle, but the right ankle's totally fine, and maybe a random inflamed joint in the right hand.
That asymmetrical, patchy presentation points toward a different mechanism entirely. It points toward gout, the spondyloarthritis group, or metabolic arthropathies, like the joint issues you see in acromegaly, which is a rare growth hormone disorder.
Let's use gout as the example for asymmetry. Why does gout only attack one joint at a time?
Well, gout isn't about circulating antibodies. It's about physical precipitation. Uric acid crystallizes and drops out of the blood. It's simple physics. Crystals tend to form in cooler temperatures and pool where gravity takes them. That's why gout famously attacks the big toe. It's at the bottom of the body, and it's the furthest joint from the warmth of the heart. The right toe might get slightly colder than the left toe one night, and boom, the crystals form there asymmetrically.
The physics of the human body dictating the diagnosis. That is so cool. Now, what about psoriasis? We talked about psoriatic arthritis earlier with the family history. Does that follow a symmetrical or asymmetrical rule?
Psoriatic arthritis is the notable, genuine rule breaker here. It is fully capable of going either way of presentation. It can be perfectly symmetrical, mimicking rheumatoid arthritis, or entirely asymmetrical, mimicking gout.
So that covers symmetry. The other geometric clue is joint size. Small joints versus large joints.
Right. Small joint arthropathy, think the delicate knuckles, the fingers, the toes, the wrists, is typical of rheumatoid arthritis, lupus, reactive arthritis, gout, and psoriasis.
And large joints, like hips, knees, shoulders.
Large joint involvement is typical of ankylosing spondylitis, reactive arthritis, generalized wear and tear osteoarthritis, and psoriatic arthritis.
I'm assuming some conditions just don't care about size and will gladly attack both.
Oh, absolutely. Several conditions can genuinely involve both small and large joints together. Rheumatoid arthritis, the spondyloarthritis group, and osteoarthritis all fit that bill.
You know, here's where it gets incredibly interesting to me. As someone just trying to absorb all these rules and exceptions, a glaring pattern just jumped out. Rheumatoid arthritis RA has shown up in almost every single list we've built today.
It certainly has. Good catch.
If you look at age, it's in the adolescent, adult, and middle-age brackets. Sex, it's part of the broad female-dominant majority. Symmetry, it's strongly symmetrical. Joint size, small, large, and both. It's everywhere.
That is an astute observation. RA is ubiquity across almost every demographic and pattern axis we've discussed, is exactly why it is considered the prototype inflammatory polyarthritis.
The prototype.
Yes. It doesn't have one narrow, easily identifiable demographic signature. It shows up broadly across populations and attacks almost any joint type. That is both its greatest diagnostic power, meaning it's the classic template we compare everything else against, and its biggest challenge for clinicians because it overlaps with and mimics so many other things.
It's the ultimate shapeshifter in the rheumatology cold case files.
It is the ultimate mimic. Which brings us all the way back to the importance of the thorough history. Because when the clinical picture is murky, when a disease like RA could be mimicking something else, or when a stomach bug is disguising itself as a knee injury, the history is the only tether you have to the actual truth.
Let's bring this deep dive full circle. Let's go back to our patient from the opening case file, the woman sitting in the exam room right now.
Okay, let's look at her complete profile.
So we now have a fully developed picture of her. She has this current state, chronic additive pain. It is morning stiffness dominant, which is a key inflammatory marker, and it improves with activity. But now we are also holding this seemingly useless old history, that transient enthesitis tight heel pain from her 20s that eventually just went away.
Right. We are faced with the final assessment. We have to combine her current state with that forgotten chapter.
There is a real tension here for the clinician, because as we've learned today, that old heel pain could be the ultimate key to the puzzle. It could be the very first chapter of a spondyloarthritis that has been slowly brewing for a decade, or, well, it could just be a red herring. Maybe she just wore bad shoes in her 20s.
Exactly. And holding that tension, not rushing to the easy answer, not just blindly relying on a uric acid lab test, but sitting with the uncertainty of the history is exactly what real diagnostic reasoning feels like. You gather the clues, you weigh the demographics, you examine the geometry of the pain, you explore the history, and you hold them all up to the light to see how they align.
It's incredible. For you listening, I hope this completely changes how you think about your own health narratives, because our bodies aren't just a collection of random, disconnected events or isolated body parts. The next time you have a, now that you mention it, moment at the doctor's office, remember that you might be handing them the very clue they need to solve the case.
You are handing them chapter 1.
Chapter 1. So as we wrap up this deep dive, I want to leave you with a final, provocative thought to mull over on your own. We've seen today how a medical history is actually a single, continuous narrative, and a skilled diagnostician has to string together these seemingly disconnected chapters. It makes you wonder, how many minor unrelated ailments are we brushing off right now? A weird rash, a random stomach bug, a month of dry eyes. How many of those are actually early warning signs, the opening sentences of a larger systemic condition that we won't fully recognize for decades?
It certainly changes how you look in the mirror, doesn't it?
It really does. Keep paying attention to your own chapters and keep digging into the details.